one of the important diseases in this subcontinent. The disease prevailing in other parts, particularly Africa and South America also. But in this, the very name of visceral leishmaniasis, synonymous with kala azar. Kala means black. In advanced cases, the whole skin of the body becomes. Let us talk about kala azar. Leishmaniasis is a chronic infection, and it mainly affects by the infection of the radiculoendothelial system, liver, spleen, lymph node, and bone marrow. It is caused by unicellular flagellated intracellular protozoa of Leishmania. Bite of infected female sandfly, phlebotomine sandfly, usually at night, the transfusion, transplantation, and transplacental. But important is the vector is sandfly, and it is the female vector which bites. Male vector cannot, even if bite, cannot transmit. Second important is transfusion-related kala azar, which is very, very rare. So you must remember that sandfly is the vector. Female sandfly is biting the usually animals, including occasionally the human being at night. What are the important risk factors? There are important risk factors. One is poverty. Poverty related to the hygienic condition of the patient. Poverty related nutritious food. So poverty, malnutrition, mud or straw houses, dam building, deforestation, immunosuppression, and HIV. Immunosuppression and HIV itself is a risk factor, but following kala azar, immunosuppressed condition occurs and there are multiple of secondary infections such as pneumonia, such as other respiratory tract infection, such as tuberculosis. So when you check any patient of kala azar, you must check presence of tuberculosis. Vector, female sandfly, Phlebotomas argentifis, live in hot and humid cracks and crevices of mud and straw houses, bites at night. These are characteristic features of vector phlebotom. Bites at night because in daytime they cannot bite. And it's common in hot and humid climates. So after monsoon rains, in this subcontinent, there is seasonal peak. If the sandfly, the organism Leishmania donovani occurs in two forms, in amastigote form and promastigote form. Amastigote form, it occurs in human body, and promastigote form, it occurs in sandfly. So when sandfly is the reservoir, promastigote form, that means with flagellated, this with the bite is transmitted to the human body and it engulfed by the neutrophil and it multiplies, and secondarily lysis occurs, and following lysis is virtually again engulfed by macrophages. So macrophage is the primary site for amastigote form of the Leishmania donovan body, LD body or Leishmania donovanis. And again from human, if there is another bite of infected human, by sandfly, the amastigote form becomes promastigote form in the sandfly digestive tract. So vector is the, and from human to human transmission is most common in our subcontinent. Diverse clinical syndrome placed into three broad categories of group: visceral leishmaniasis or Kala-Jar, black fever, sometimes known as black sickness, but black fever, because there is febrile episode, and in prolonged long-term cases, the color of the skin becomes black. So, very popularly known in this subcontinent as Kala-Jar. There was about 100 years back, there was epidemic of Kala-Jar, where thousands of people of this Bengal and Assam were they died. Cutaneous leishmaniasis is oriental sore, most common in Saudi Arabia and the other Middle East regions, and mucosal leishmaniasis is quite common in South America, such as in Brazil. We will concentrate on visceral leishmaniasis or Kala-Jar because this is quite prevalent in our country. Clinical features, weeks to months is quite common, occasionally several years. A case from Sudan after the Second World War was diagnosed about 3 years after the first infection that this was a case of Kala-Jar. Fever, high, hectic with chill and rigor. Then there is a febrile intervening period, weeks to months. During this period, high fever, there is usually double peak in 24 hours. This is considered to be one of the characteristic features of Kala-Jar, double peak in 24 hours. Then subsequently, there may be a febrile intervening period for weeks to months, and there is relapse of the fever with low grade, less intensity, but clinically there is usually after the first or second week there is progressive splenomegaly, hepatomegaly, and in other countries, not in this subcontinent, lymph node enlargement is the prominent feature. All these three conditions constitute together, and the littoral cells of the bone marrow constitute together the reticuloendothelial tissue. Since there is infiltration to the bone marrow by the LD body, Leishman-Donovan body, or amastigote form of Leishmania donovani, so there is suppression of the production of red cell, white cell, and platelets, leading to pancytopenia. Early characteristic feature is progressive neutropenia with relative lymphocytosis and monocytosis. Monocytosis is the hematologic or blood counterpart of the macrophages. In tissue, monocyte becomes macrophages. So, these are the important cells where inside this cell you can find the LD body. In chronic cases, blackish discoloration of the skin occurs. There is hypoalbuminemia leading to pedal edema, ascites, and anasarca, and there could be bleeding. Nose bleeding is quite common, but bleeding from GI tract, retina, and nose. Nose bleeding is quite common. Retinal bleeding and GI tract bleeding is very uncommon. Very characteristic feature is splenomegaly. There could be massive splenomegaly. When we use the term massive splenomegaly, usually if spleen crosses the umbilicus, then we label the case as a massive splenomegaly. So rapidly developing massive splenomegaly with initial weight loss and lymphadenopathy is very rare in this subcontinent. Could be hepatomegaly is usually moderate. So apart from lymphadenopathy, you should remember splenomegaly, rapidly enlarging, hepatomegaly, moderate, progressive anemia, and bleeding tendency. All these features could be the cause of Kala Jor. Investigation. Which investigation will prefer first? Definitely blood count. Pancytopenia and progressive neutropenia, lymphocytosis and monocytosis is the characteristic feature. There could be hyperalbuminemia and polyclonal hypergammaglobulinemia. Usually this is not done. And Barcode smear to see the parasite, we will discuss this later. PCR is not regularly done in this country. So when you suspect Kala Jar, investigation of choice is CBC. Second is bone marrow examination. And third is lymph node aspiration if lymphadenopathy occurs. But highest is found in splenic aspiration, 98% positivity in this clinical aspiration, about 85 to 90% positivity in bone marrow aspiration. But splenic aspiration in presence of pancytopenia is hazardous because it can lead to splenic aspiration in presence of pancytopenia is hazardous because it can lead to massive intra-abdominal or splenic hemorrhage that may lead to death in inexperienced hand. So, splenic aspiration, if decided, should be done by expert hand, not by a novice. But commonly for CVC and bone marrow aspiration to study the amastigot form of the Leishmania donovanis in the macrophages inside the bone marrow. And Barcode preparation is very simple. You have done in your physiology practical classes how to determine the packed cell volume. You take blood in a Winthrop tube and it is rotated at a very high speed and the cell content collects at the upper, particularly WBC, appears and concentrates, floats in the upper surface and the rest of the fluid is below. The WBC looks white, pale white, and this coat is known as Buffy coat with a if you can collect the Buffy coat and make a smear and after staining, right stain or Leishman stain, if you see under microscope, you can see the many macrophages contains the parasite LD body. So Buffy coat sample is very simple, can be done in Thana Health Complex and yield is 95% more than the bone marrow. So that can replace with the experienced microscopist that can replace the preparation for bone marrow and study of the bone marrow. Serological diagnosis could be helpful. Direct agglutination test It was done in IDCR in Mohakali, immunofluorescence antibody, but nowadays in our country, immunochromatographic K39 or K39 test is very, very important and widely popular in this subcontinent. Immunochromatographic test RK39, but direct agglutination test is also. Demonstration of the LD bodies, clinic smear 98% sensitivity, bone marrow around 80% sensitivity, and I have already mentioned Buffy code preparation is 95% sensitivity. Lymph nodes is very unusually enlarged in our country, so that is not routinely studied. So demonstration of the LD body, first and foremost easy is bone marrow, then splenic smear in expert hand, and then Buffy code preparation. So direct you can visualize the LD body, a masticode form of the Leishman-Donovan body. So this is how RK39 strip test is done. This is very easy. Blood is taken, diluent buffer is added. After 10 minutes, with this strip, the color changes are noted. So there is double mark in the positive one, no mark in the invalid one, and one line in the negative one. So this is RK39 strip test can be done even in the medical ward if the strip is available. So these are complications of Kala-Azar, post-Kala-Azar dermal leishmaniasis. It's dermatology, papules and nodules and plaques all over the body with a past history of Kala-Azar in the past. Face becomes nodular and often differential diagnosis becomes lepromatous leprosy. Slit skin smear and culture RK39 test, these are two tests. So profile is seen with papules, multiple papules, but the nodules are very prominent in face view. You can see multiple nodules. It also one of the important differential diagnosis is Leishmania, Donovan post Kala-Azar dermal leishmaniasis. One important diagnosis, differential diagnosis is lepromatous leprosy. Management supportive, adequate nutrition, infection control, and blood transfusion if needed, if the patient is severely anemic. So when you transfuse your patient of severe anemia, always give packed cell, otherwise there will be every risk of circulatory overload or fluid overload. And first line treatment is drug of choice, liposomal amphotericin B, 10 milligram per kg body weight, intravenous single dose. This is now recommended and routinely practiced in Bangladesh. Liposomal amphotericin B, and in all government medical colleges, this drug is supplied and it's a very costly drug. One vial costs about 4,000, 5,000 taka. So liposomal amphotericin B, 10 milligram per kg body weight IV and single dose. Alternative is miltefosine. It is orally 2.5 milligram per kg per day in two divided doses for 28 days. 2.5 milligram per kg per day in two divided doses, 28 days. And paromomycin is given gluteal muscles once a day, 15 milligram per kg per day for 21 days. So, liposomal amphotericin B, miltefosine, these can be combined together in refractory or resistant cases. But for your purpose, you remember liposomal amphotericin B is the drug of first choice. Oral drug is miltefosine. Oral drug is miltefosine. Sodium stevogluconate is a very toxic drug in our student or in early our profession. We had to rely on this sodium stevogluconate because we did not have any other preparation. 20 milligram per kg per day intramuscular or intravenous. Very slow intravenous, but it is toxic. Cardiotoxicity is there, and there could be thrombophlebitis, even there could be allergic anaphylactic reaction. So, second line drug particularly is not preferred, as sodium stevogluconate is never a drug of first choice nowadays. If never a drug of first choice is amphotericin B or miltefosine is available. So, forget about everything else. Please remember only two: amphotericin B, drug of first choice, and alternative amphotericin B, liposomal amphotericin B, 10 milligram per kg IV single dose. This is the drug of first choice. Second choice is oral miltefosine, 2.5 milligram per kg per day in two divided doses. Duration is 28 days. Duration is 28 days. Paromomycin is not available in our country, but in a very resistant cases, it is commonly combined with other two drugs, miltefosine or liposomal amphotericin B. In resistant cases, particularly which is very dominant in Bihar state of India. So, treatment of relapse or treatment failure cases. If you have tried with miltefosine, next time try with amphotericin B, liposomal amphotericin B. If you try with amphotericin B, next time you will try with miltefosine. And the same treatment of miltefosine for post-Kalajar dermal leishmaniasis. 100 milligram in two divided doses, adult, 2.5 milligram per kg per day, two divided doses. Duration is 12 weeks. For visceral leishmaniasis, duration is 4 weeks, but here duration is 12 weeks. When you can be assured that your treatment is successful, improvement of all parameters, fever, the patient will become febrile, and during treatment you can measure the spleen and mark it that every weekly or every third day how much spleen is getting smaller. Initial size could be 10 centimeter and subsequently it could become 7 centimeter after a week. That suggests that reduction of the splenic size during treatment of Kalajar signify successful treatment. And another is weight gain during treatment. And definitive treatment, no fever at 6 months, which is considered to be cured. No fever is 6 months, substantially reduced splenic size, or spleen is not palpable and feeling of general well-being, patient feels better and comfortable. So this is how, so if we simplify, how do we assess the initial cure and definitive cure? Improvement of the clinical parameters, reduction of the splenic size, gain of body weight, and improvement of the general well-being and appetite. Complication. I have mentioned already that Kala-Azar is a immunocomplication, immunosuppressing condition. Profound immunosuppression occurs because of the neutropenic condition, pancytopenia occurs even. So tuberculosis is quite common, pneumonia, gastroenteritis, dysentery, balls, cellulitis, chickenpox, shingles, and scabies. So you can include here, you can see there could be pneumonic bacterial infection, chickenpox and shingles are viral infection, scabies is a parasitic infection. So all kinds of infection is highly prevalent during the immunosuppressed condition of Kala-Azar. And without treatment, mortality is 95%. If you do not treat a patient of Kala-Azar, mortality is 95%. And about 100 years back, there was an epidemic of Kala-Azar in the Bengal, and almost 20% of the total population of Bengal and Assam lost their lives because of that epidemic. Follow-up during treatment, usually immediately after completion of treatment, and ultimate follow-up should be done on first month, 4 month, 8 month, and 12 month. So 1 year follow-up is necessary because there is a risk of relapse. Detection of cases and treatment, because human is the only reservoir in this society. So vector is the sandfly. If infected person is bitten by a sandfly, and again an infected person is bitten by the same vector, sandfly, so there is easy transmission. So early detection and of cases and treatment, successful treatment reduces the number. Improvement of housing, because hot, humid environment facilitates the production or replication of sandfly. So improvement of housing and sanitation is important. To kill the sandfly, spraying insecticide, avoidance. Spraying insecticide is common, and avoidance of sleep on floor. Using mosquito nets, repellents, these are useful to prevent bite by sandfly. So this is about prevention of Kala-Azar. So thank you. If you do have any question, please feel free to ask me.
ফিভার তো অন্য কোনো আসতে পারে?